Good morning. It's my pleasure to introduce today's speaker, who's Ashley Lewis. Dr. Lewis is currently a geriatric psychiatry fellow in the Department of Psychiatry at Shands. She originally grew up in Chicago and then in Florida. And she went to medical school at Meharry Medical College in Tennessee, and also did her general residency training there. So I don't know how she feels about being anxious, but anyway, she's going to give us a talk this morning on anxiety in the older people. I guess that's us. Thank you.
Welcome, Dr. Lewis.
All right, thank you guys so much for having me. I hope you guys can see me. I can't really see myself, so I'm assuming you guys can see me and you can see the slides. Today, we are going to be talking about anxiety disorders in the elderly. So some objectives for the presentation today, we are going to kind of just define what is anxiety. We're going to discuss diagnosis and criteria for anxiety disorders as they pertain to the DSM-5, discuss pertinent epidemiology, as well as identify anxiety in the elderly, and also talk about treatment options. So what is anxiety? Anxiety is a mental health condition characterized by excessive apprehensiveness about real or perceived threats, typically leading to avoidant behaviors and often to physical symptoms such as increased heart rate or muscle tension. Some risk factors for anxiety disorders in the elderly are being female, being single, divorced, or separated, life events, adverse events in childhood, lower education, as well as health issues, grief, or loss. Before making the diagnosis or seeing if you have a diagnosis, when you're having those symptoms of what we call anxiety or feeling overwhelmed with certain issues, you want to make sure you go see a health professional. So there are certain things that can be ruled out, such as medical conditions that can mimic anxiety. So medical conditions such as heart disease or certain medications that can mimic anxiety, such as steroids. As well as getting certain labs such as TSH, which shows us how our thyroid is doing, and that can also mimic anxiety disorders, as well as ruling out certain substances or withdrawal from substances before making an anxiety diagnosis. So, what are the anxiety disorders according to the DSM-5? The DSM-5 is like our Bible. I think we mentioned it a little bit last week when we were talking about depression. So some of the anxiety disorders are separation anxiety, selective mutism, specific phobias, social anxiety disorder, panic disorder, post-traumatic stress disorder, generalized anxiety disorder, substance/medication-induced anxiety disorder, anxiety due to another medical condition, or unspecified anxiety disorder. So there, in regards to specific phobias, a specific phobia could be something like public speaking. So fear out of proportion to actual danger, leading to avoidance of triggers. These symptoms happen longer than 6 months. We're not going to touch on that too much in this presentation because specific phobias as well as social anxiety disorder isn't as prevalent in the elderly. The disorders that we are going to focus on in this presentation are the ones that are highlighted. So panic disorder, post-traumatic stress disorder, as well as generalized anxiety disorder.
Some of the signs and determining factors when you look at adults for anxiety disorder. Anxiety is an irrational fear a person goes through. Anxiety is a natural instinct in a person. Whenever you see a danger, that's how your body reacts. When it becomes overwhelming, where they are not able to function, then it becomes a disorder. So anxiety disorders, they can come in spurts, or sometimes they may stay anxious throughout the day. There's an irrational fear. Sometimes they may have palpitations and dizziness, nausea. They may come with so many different somatic symptoms in the body. So when you suspect those symptoms, when you see those symptoms on a daily basis, it is time to take them to the primary care doctor.
And so I picked that video, and what I liked is for us to talk about a little bit is how some anxiety is normal, some anxiety is good for us. Like when I had to prepare for this presentation, if I am anxious, having some anxiety for the preparation is okay. But where it becomes a disorder is if, no, I didn't get any sleep last night. I can't focus. I can't concentrate. Things that I wanted to say, I can't say because I can't concentrate because the anxiety is just boiling up. And that's kind of where it becomes a disorder versus the healthy anxiousness that we have presenting in front of others.
Some of the signs and determining factors when you look at it.
Okay, so generalized anxiety disorder, this is the criteria that we use for generalized anxiety disorder. So it's when you have excessive worry or anxiety about a number of events. The individual can't control the worry. The anxiety or worry is associated with 3 out of 6 of the following. So you can have restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, having irritability, muscle tension, or sleep disturbance. Also having a significant clinical distress or impairment in social, occupational, or other important areas of functioning. And you have to make sure this disturbance is not due to substances such as drugs of abuse or medications, as well as another medical condition, like we talked about, hyperthyroidism, as well as not being better explained by another mental disorder. Panic disorder. Panic is when you have recurrent, unexpected panic attacks. You have an abrupt surge of intense fear or intense discomfort that reaches its peak within minutes, during which you'll have 4 out of the following symptoms. So you can have palpitation, which is heart pounding, sweating, trembling or shaking, sensations of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea, abdominal pain, feeling dizzy, lightheaded, chills or heat sensation, derealization, feeling of unreality or depersonalization, feeling detached from oneself, fear of losing control or fear of dying. Along with those symptoms, you also have to have the attacks for at least 1 month, and worrying about an additional attack and their consequences, or having significant maladaptive change in behavior related to the attacks. But once again, the disturbance or the events cannot be attributable, cannot be due to drugs of choice, medications, or another medical condition. So there's kind of like a running theme when it comes to the diagnoses in the DSM-5. It can't be due to drugs of choice, medications, another medical condition, or it can't be due to another mental disorder. Talking about post-traumatic stress disorder. So post-traumatic stress disorder is when you have exposure to an actual or threatened death, serious injury, or sexual violence in one of the following ways. So it can directly happen to you if you witnessed it, or if you learn that it happened to someone close to you, like a family member or a friend, as well as experiencing repeated or extreme exposure to traumatic events, such as being like a first responder, a police officer, a firefighter, or anything like that. Other symptoms that you can have in regards to PTSD will be those intrusive thoughts or distressing memories of the event, as well as having recurrent dreams or flashbacks from triggers, as well as avoidant behaviors to avoid the distressing memories, as well as negative thoughts about oneself and feeling detached or estranged from others, as well as marked alterations in arousal, such as exaggerated startle response. So when it comes to the epidemiology of anxiety in the elderly, there tends to be a big range, and we'll kind of talk about why that is. So prevalence of anxiety disorders in the elderly can range from 1.5 to 15 in community samples and 1 to 28 in the medical settings. And this is thought due to the diagnostic criteria and the methods used to observe them. So an example of that would be if somebody has like a fear of falling, and that's kind of what's causing the anxiety, this may not be discerned by our standard assessments of methodology. So that means that it was very difficult at times to make the diagnosis because it presents a little bit differently in the elderly. So it kind of talks about it a little bit more, detection and diagnosis complications. So some of the things that make the detection and the diagnosis complicated would be cognitive decline, medical comorbidities, different experiences and expression of symptoms, as well as you might not meet the full criteria for the significant distress. And the reason behind that would be it would be harder to assess the disruption of functioning due to no longer working or fewer daily obligations. And so when talking about the difference of experience and expression of symptoms, once again, when somebody presents with anxiety disorder in the elderly, they can have more of those somatic symptoms versus, the sweating, the tremors, the lightheadedness. They can feel more of when I say somatic symptoms, it will be more of like pain. You will still have like the abdominal issues or something like that. But what ends up happening with the elderly presenting with more somatic symptoms is they'll go to their primary care physician, which you do want them to do to rule out medical conditions, but you might not diagnose that underlying anxiety because they're presenting more with the somatic symptoms, as well as having a history of undiagnosed disorder. So if you've gone basically your entire life with this certain level of anxiety, even though it might be clinically diagnosable, you're used to it at this point, and you may think that extreme level of anxiety is normal. So most common anxiety disorder present late in life. So the most common anxiety disorder that presents late in life is generalized anxiety disorder. And as many as 24 to 46% of the cases can develop late in life. It can present with more sleep disturbances, fewer assurance-seeking behaviors, greater degree of disability in self-reported measures of impairment in social and familial functioning, as well as a greater severity of co-occurring depressive symptoms. So you can also present with a comorbidity with depression. So you can have both anxiety and depression. And if you present with both diagnoses, you will present with those greater somatic symptoms of the pain, the fatigue, those abdominal issues, as well as having a higher risk of suicide. So I just want to mention at this time that if you're having any of those thoughts, you want to make sure any of those thoughts of not wanting to be alive, not wanting to wake up in the morning, or wanting to actively hurt yourself, you want to make sure that you go and see a medical professional so you can talk about those feelings and see what is the best method of help at that time. It's also reported that if they present with both anxiety and depression, they may need a longer time to experience treatment response. Having a diagnosis of generalized anxiety disorder, regardless of age of onset, can also increase your risk for other medical conditions, such as stroke and other cardiovascular events. It can also increase the risk of having a concurrent diagnosis of substance abuse, additional anxiety disorder, and major depressive disorder. And so, one of the reasons of having these presentations is to make sure we get the information out there so these conditions can be treated and we can improve quality of life. And that is the main objective of having these presentations, not to necessarily worsen or increase the worry of this increased risk of stroke or other medical conditions. We just want to make sure to get the information out there so you guys can increase your ability to be able to recognize the symptoms and seek treatment if necessary. Some assessment tools used to diagnose anxiety. So this is an example of the Beck Anxiety Inventory. And so it's not the full thing, but it's kind of just an example of things that will be asked when you're filling out the Beck Anxiety Inventory. So they're asking more about symptoms of numbness or tingling, feeling of hot, wobbliness in legs, unable to relax, fear of worse things happening, dizziness or lightheadedness. And so when you're filling this out, they're asking not at all. Are you feeling this at all? Mildly, but it didn't bother me much. Moderately, it wasn't pleasant at times, or severely, it bothered me a lot. And so these are the kind of things that they're assessing when you are asked to fill out the Beck Anxiety Inventory. As well as there's another one called the Penn State Worry Questionnaire. And so this one's a little bit different where it's talking about situations. So if I don't have enough time to do everything, I don't worry about it. My worries overwhelm me. I don't tend to worry about things. Many situations make me worry. I know I should not worry about things, but I just cannot help it. And so on this one, they're talking about not at all, typically, not very typical, somewhat typical, fairly typical, and very typical. So that's the difference between these two assessments, but they're both trying to see how much worrying are you doing from day to day. Some common anxiogenic stressors, so having a chronic illness, caregiver status, bereavement, medical conditions can also exacerbate anxiety in the elderly, such as dementia. Aging can be a source of some anxiety for some, as well as fear of falling, fear of being a burden on family, financing, and losing independence. Panic disorder, development of panic disorder late in life is rare. So if you happen to have a new onset panic disorder later in life, these symptoms should prompt your provider to do a medical workup. Because once again, we want to talk about those medical causes that can produce similar symptoms to anxiety. So it would be those cardiovascular symptoms, pulmonary symptoms, or neurological symptoms. So you're trying to exclude things like arrhythmias, COPD or asthma, hypoglycemic state, as well as thyroid dysfunction or seizure disorders. So if you have these things, what do you do next? What are the treatment options? So some of the treatment that is one of the main treatment options that we have is cognitive behavioral therapy, as well as some medications. But if we start with cognitive behavioral therapy, we will try and do some psychoeducation, teach relaxation, cognitive therapy, problem solving, as well as exposure exercises. And when it talks about medications, SSRI, which is the serotonin reuptake inhibitors, so those are like Zoloft, Celexa, and then the SNRIs, venlafaxine and Cymbalta. These are the most studied in the elderly when we're talking about anxiety disorders. Some other treatment options would be yoga, meditation, deep breathing, exercise, as well as having a healthy diet, as well as learning triggers, gaining coping skills, and self-monitoring. So when I say learning triggers, what does that mean? And I put all those together to kind of be like it can be like a 1, 2, 3 kind of. So when you're self-monitoring, when you're feeling those anxious feelings and you're becoming overwhelmed, you can kind of write it down and write down what's happening in the moment. And that's how you'll kind of learn your triggers at the time. And you can keep a diary, a self-monitoring diary, learning your triggers as well as what helped in the moment. And that's how you'll gain the coping skills. So different coping skills can be things on the left: yoga, meditation, deep breathing, exercise, listening to music, calling a family friend, anything of that nature. So I thought it would be fun if we don't have to listen to the entire video, but I was thinking that we can kind of do a few minutes of this mindfulness exercise and meditate to kind of calm our mornings down.
Welcome to the Daily Calm. Let's start today's session by finding a comfortable position with a tall, straight back. Allow your arms to rest gently. When you're ready, close your eyes. Bring full attention to this very moment. Settling in and allowing the mind and body to still. And with openness, patience, and curiosity, bring your awareness to the breath. Taking a deep breath in and releasing it fully. Follow the breath as it flows in and out of your body. And we'll scan down the body now, concentrating our attention from part depart. Start by bringing your attention to the top of your head and scalp, feeling whatever's happening in this area. You might feel tingling or heat, throbbing or soft vibrations. There may be strong sensation, or you might not feel much at all. Now lower your attention to your forehead, face, and jaw. Allow the muscles here to relax. On your next out breath, let that sensation dissolve. Lower your focus to the neck, letting the throat and sides and back of the neck soften. Notice any sensation that arises on the surface of the skin or deeper within. Now bring your attention to your shoulders, noticing if there's any tension or strain. Breathe into your shoulders, and if any parts feel tight, allow them to relax. Extend your awareness down the arm, towards the wrists, palms, and fingers. On the next out breath, allow them to soften. Now come to the chest, observing the rise and fall of each breath. Notice how the lungs expand and contract. Direct your attention to your upper and lower back. There may be some intensity.
So the take-home points for this presentation: some anxiety is normal and necessary. The most common anxiety disorder in the elderly is the generalized anxiety disorder, as well as make sure to rule out medical conditions that can mimic anxiety disorder and then the treatment. So things like meditation, yoga, therapy, as well as medications if you and your provider feel like that is necessary and appropriate at that time. Thank you for listening. So I guess I have some questions. How many, if it's no one, that's okay, but does anybody feel like the video was helpful and of the mindfulness, and it's something that can be incorporated into like a daily routine?
Well, if we have any questions here in the Oak Room or any online, feel free to raise your hand.
I don't know. Did you guys hear my question?
They were being shy, I think.
I have a question for you in the audience here. You had on one of your slides that anxiety can lead to dementia, or is it dementia that leads to anxiety? Which way does it go?
So
Can
anxiety
anxiety then develop into dementia over time in the elderly?
so anxiety can cause mild cognitive impairment to turn into like Alzheimer's disease.
Yeah. So, what, excuse me, what are the hormonal background? I know you mentioned TSH, but what about the adrenal? You did not mention that because that's involved with stress and then anxiety and of course dementia.
Right. I didn't go too far into that. So one of our main stress hormones will be cortisol. And you're right. So that would be some of the things. I didn't go too far into that because I wasn't sure if the group would be interested. So yes, increased cortisol levels is our stress hormone.
Hi. You mentioned thyroid condition, and you mentioned hyper. I have hypo, and until I was diagnosed, I suffered from a couple of those things, and so I think it's also in hypo. And as a child, they didn't have the diagnosis ability that they do now, and so I probably had it all my life, and anybody who has it could blame themselves rather than, partly from the disease. Well, it isn't a disease, a condition.
You are 100% correct. So on one of the slides, I did just mention TSH. So TSH is kind of what is the hormone that we use to see how our thyroid is working. And that will let us know if it's high or low. And you're 100% correct. Both conditions, hypo or hyper, can cause those kind of symptoms. And so you're also 100% correct where now we have a lot more information out there. And so that's why we're trying to make sure that we're getting the information out there. We're letting people know, hey, you could have been experiencing this all along and we just didn't have the materials to diagnose you earlier. And I think I mentioned that as well. You could have been living with this anxiety your entire life, but you actually do have an anxiety disorder. But back then it was just, it wasn't picked up. And now we're trying to make sure the information is getting out there so we can improve quality of life and teach people how to deal with this anxiety, like using coping skills, exercising, different coping skills, and realizing what their triggers are so they can increase quality of life.
Other questions? Nobody seems very anxious here, I must say.
There's a hand raised.
Go ahead, Lynn.
Oh, thank you. Yeah, my mother had Parkinson's when she was alive. And wouldn't that be quite normal to be anxious? Because you're always fearing that you're going to fall. And follow-up question, because you didn't talk about Parkinson's specifically, is shouldn't people who are evaluated as having Parkinson's also talk to somebody about the anxiety issues?
100%
for that.
Yes, you are 100% right. So when I listed the diagnoses, I think I just was giving some example. I didn't list all, but you're 100% right. When people have things like Parkinson's, they are worried. Currently, I'm in a movement clinic. And so we treat people with Parkinson's and different movement disorders. And they talk about how, they worry about their symptoms worsening in public or them not being able to complete their errands and different things. So 100%, you can have those symptoms in many medical conditions, and we want to make sure you talk to a medical professional and about these symptoms so you can get treatment. 100%. I'm glad that you brought that up.
So one issue that you alluded to but doesn't really cover is substance abuse and its association with anxiety. Could you say just a few words about that?
Yes, so 100%. So when it comes to substance abuse, there's a lot of people that, you know, when they're feeling down or anxious or can't sleep, they may use some kind of substance like alcohol, cannabis, any of these things. But what we've seen is that these substances tend to worsen anxiety. And so that's what I meant by substance abuse, or when you're withdrawing from a substance that you've taken, you can also have those symptoms of anxiety. So that's why you have to make sure you're ruling out, you know, do you drink alcohol? Do you smoke cannabis? Are there any other substances that you can use? Benzodiazepines is something that we treat for anxiety, but if you're using a shorter acting benzodiazepine, maybe coming when the medication is wearing off, you can feel the withdrawal from that medication, so your anxiety might increase. So those are some different things that when you're talking about substances. Does that kind of answer your question?
Yes, but just a slight extension to that. Cannabis is being used as therapy by a lot of people today. And
Yes,
so
it
the
is.
question is, to what extent do you find that that's contributing to the anxiety problem?
Well, I think there's a difference between one, overall, the answer is they're still doing research on cannabis and how it can be beneficial for different medical conditions. But also, I think people using CBD can be a little bit different as well, because there's not as much as the THC. And even with that, like the data is still being collected. So that is kind of a very loaded, difficult question. But yes, some people are using cannabis for anxiety, for sleep disorders, for eating disorder, you know, if they don't have that appetite, depending on, you know, in cancer and different things. But currently in the DSM-5, it still can contribute to an anxiety disorder. So it can increase anxiety.
Can I ask a question, Ken?
Yes, please.
I'm a retired teacher in elementary, and I would find that children could be misdiagnosed, kids with depression diagnosed with anxiety or vice versa. And I'm just wondering, how much damage does that do? Like, if you're not really identifying the correct condition.
So it all depends. There could be two trains of thought. So one, if they're saying they have a depression, but it's really anxiety, you're treating it the same. So the person can still get the treatment. So it's a little okay. I guess the problem will come in if they're diagnosing them with like a psychotic disorder and they're on an antipsychotic versus a antidepressant. So that's a difficult question to answer, but hopefully the child was still getting the correct medication, even though the diagnosis can be teased out a little bit.
Well, and even for seniors, you know, just making, I guess it really comes down to clarity and honesty with the provider and making sure that you're really being specific, because the symptoms seem to overlap so much.
Right, that's what I was going to say next. The symptoms seem to overlap so much, and you see we have questionnaires. So it's kind of, we rely on you guys a lot, and the reporting, and you know, sometimes it's difficult for the person to 100% remember like what was really going on. So sometimes it is a little bit of like trial and error, but for the most part, I hope that, you know, they continue to work on the diagnosis and don't like see the person just one time and say, okay, that's it, and then treat them for that for, forever. If they're seeing something else might be the actual diagnosis.
Thank you. Ken?
Okay, well, is there another question in the audience? There's not, so at this point I'd like to thank Dr. Lewis for a very clear talk this morning.
Thank you guys so much for participating. I hope you guys like the mindfulness video.
Next Monday, we'll have a talk on schizophrenia. So we look forward to that.
And then we'll see Dr. Lewis as our last presenter as well.
Yeah, we actually might be doing it together.
She'll be back. We're not done with her yet. Or she's not done with us, let me put it that way. So once again, thanks very much.
Thank you so much.